All right, we'll give everyone a minute or two to hop on before we get started, so we'll just all hang tight for a moment. People are coming on, just hang tight. We're going to get started a couple minutes after 1 o'clock here. Just want to give everyone a moment to get on. Hi, Samara. I see one of my students on there. That's nice. She apparently didn't get enough punishment in my class listening to me talk. She's going to be on here today. Give it another minute for everyone to get on. I think we had like 64, 65 pre-registered as of last night, so I'll let the number tick up a little bit more before we get started. As you're getting on, just keep in mind this is not a standard Zoom call. This is Zoom webinar. We will not be able to see you, and you will not be able to talk directly to the panelists. However, we will have the Q&A feature enabled, so just bear that in mind. You're just a viewer on this one more than actually somebody that's participating in the conversation. We'll give it about another minute, and then we will rock and roll. Climbing up a little bit. All right, well, I think we will get started in the interest of time. I'd like to welcome everyone to our third webinar of our Health and Fitness and COVID-19 series. Today, we're going to be talking about serving the vulnerable populations, that is the elderly and the immunocompromised. And certainly these are challenging populations to get involved in health and fitness and self-care endeavors under normal circumstances. And in these circumstances are even more remarkably challenging in terms of getting these individuals engaged in our programs. We're very fortunate to have a panel of 4 experts who are going to be able to help us navigate this particular area, which I think is a very, very important topic, as they'll discuss. Before we actually launch into introducing the panelists, I'd like to explain a little bit of some logistics and housekeeping for the webinar. First and foremost, this webinar is being recorded. It's going to be archived on the School of Kinesiology YouTube channel, so you'll be able to view it there along with our other 2 webinars we did in this series earlier this summer. We'll be sending out an email likely within the next 24 to 48 hours with a link to that recording if it's something that you want to view after the fact, as well as any resources that we talk about during today's webinar that we want to be able to send to all of the panelists. Lastly, again, as I was mentioning as people were getting on, we will not have the ability for you to interact directly with any of the panelists. This is a Zoom webinar, so not like a standard Zoom meeting. The Q&A feature is enabled. Please feel free to use the Q&A feature to ask any questions you have of the panelists. Bear in mind, because we're trying to keep this to an hour, we may not be able to answer every single question during the webinar, but certainly we'll make every effort after the fact to have those questions answered for you in the form of a follow-up email. With that said, I would like to introduce all of our panelists. We have 4 people that have a great degree of expertise in this area that we're very excited to have. First, I'd like to introduce NiCole Keith. She is the president of the American College of Sport Medicine. She's also the associate dean for faculty affairs at IUPUI School of Health and Human Services, and she's been a very busy lady with the ACSM, sending her out to do many, many webinars and video meetings over the course of the past several months. Very happy to have NiCole joining us.
Thanks for having me, Mike.
Thank you. Robert Boone is the president and CEO of the Medical Fitness Association. For those of you that don't know of the Medical Fitness Association, they're an organization that's dedicated primarily to the development and certification of medical fitness centers that are generally associated with hospital systems and have a lot of experience and background working with the populations we're going to talk about today. Bob, thanks for joining us.
Glad to be here.
Matt Koziol is a physical therapist at University of Michigan Medicine. He actually works directly in University of Michigan hospital system, so he's not in a satellite clinic. He's kind of right in the midst of it, so he's definitely been kind of front and center during the COVID pandemic working with these populations. Matt, thanks for joining us.
Thank you.
And last but certainly not least, Jeff Young is joining us. Jeff is the owner of JYKinesiology. He's a certified strength and conditioning specialist as well as an exercises medicine practitioner for the ACSM. He has extensive background in healthcare and medical fitness settings and thereby a lot of experience with these populations. So Jeff, thank you and your amazing background for joining us.
Thank you very much.
Awesome. Well, guys, we're going to get right into this and probably with the maybe most important foundational question to answer right off the bat, which is let's talk about the public health implications of working with these vulnerable populations, and not just in general, but also kind of through the lens of the COVID-19 pandemic. And NiCole, I'll start with you. Why don't you talk a little bit about the importance of working with these groups?
Well, engaging older adults in exercise in general is very important. It's important to recognize that they have a lot to offer for our future and a lot of institutional knowledge about our communities. And so it's really important to keep them healthy, both physically, but also cognitively. And aerobic physical activity as well as resistance training will do that for older adults. In the context of COVID-19, it becomes more challenging because a lot of the opportunities that older adults have to exercise at low cost come in fitness centers and come in community resources like parks and walkable sidewalks. And some older adults like to exercise at home, but getting them the resources to do so safely and efficiently is a challenge. Older adults have told me personally since COVID-19, they don't want people in their homes. And many of them are learning to access technology, but it's not something that they have done with great experience. And so making adjustments so that older adults can remain healthy and active during COVID-19 in untraditional ways is really important.
Yeah, absolutely. And those are some ways we're going to get into as this conversation evolves. How do we actually overcome some of these barriers and hurdles? And to your point, NiCole, the general challenges have just been amplified by the pandemic. Bob, how about from your perspective? You know, you sit here as the person that runs a medical fitness organization with some big facilities with large senior and immunocompromised populations. How do you see the importance of this just in the overall context of public health?
Well, as NiCole said, I think it's really critical that older adults be involved in some form of exercise for just numerous reasons, not only for their physical health, not only for their mental health, but exercise has been shown to improve immune response, has been shown to impact virtually every chronic disease in a positive way. So it's so important, and that many medical fitness facilities across the country have been declared essential businesses during this time of COVID so that we can continue to see these vulnerable populations and for physician-referred exercise. So this is it's kind of what we do. It's kind of the critical factor and a differentiator between medical fitness facilities and many commercial fitness facilities. So during COVID, our associations worked very closely with the CDC, and we developed a set of reopening guidelines specifically for the pandemic and specifically for working with these vulnerable populations, where we focus not only on the social distancing that everybody talks about, but we believe that social distancing is not enough. So we do what we call enhanced distancing. And that's based on some studies that were done in the Netherlands and Belgium that showed something very, very interesting and frightening, frankly, that someone walking at a slow pace of 2.5 miles an hour generates a slipstream, as you may all know. And within that slipstream, the turbulence in the slipstream keeps the virus airborne, not for 6 feet, but for up to 15 feet for someone walking at just 2.5 miles an hour. And for someone riding a bicycle at 20 miles an hour, it keeps it airborne for around 60 feet where it's still breathable in the face. So we've developed enhanced distancing guidelines whenever there's dynamic motion involved, particularly around these vulnerable populations. So we have encouraged our members to see these patients first and not more so than their general members, and bring them inside the facility as opposed to having them outside the facility if they can meet our our guidelines, which includes airflow and all kinds of spacing and all kinds of other pieces and parts that I won't go into. But from a public health perspective, I believe it's absolutely critical to keep these folks engaged for their own mental health, for their own social health, but we've got to keep them physically distanced. I hate the term social distancing. I refuse to use it because it implies social isolation, and there's so many people that we're seeing increased depression. We're seeing all kinds of other things going on. So I always say we must physically distance but remain socially engaged. And so that's what we try to create the atmosphere within our centers to allow people to remain physically distanced, but have social engagement, mental stimulation, and as well as physical activity that improves response, immune response.
Yeah, absolutely. And I think both of you said it to kind of capture it. You know, working with these populations is kind of a first area of emphasis instead of an afterthought. It becomes even more important now. I mean, these are the populations that are almost the forgotten individuals in the fitness community as a whole. And you know, what you're both suggesting is, hey, these are critically important people, not to just think of as the last population we work with, but to think about as the first, which I think is a great point. And Bob, you mentioned those reopening guidelines. Those are something that we have. We've shared those in our previous webinar, and we'll make sure we share those again with everyone that's watching. The MFA did a really tremendous job of developing some extensive reopening guidelines, so we'll definitely share those.
Thank you.
So let's get into something a little bit more tactical and practical here, which is the indications and contraindications for in-facility exercise and or treatment. I mean, I know there's a number of fitness professionals that are watching this, and also other allied health professionals, but they're also just members of the general public watching this. And when we talk about indications and contraindications, quite literally we mean the reasons, you know, that you should consider doing this and the reasons that you might want to be a little bit more cautious. And certainly this is a time where we're trying to take an abundance of caution approach to what we do. So Jeff, I'm going to start with you. Why don't we talk a little bit about kind of the indications and contraindications? It's probably more of an emphasis on the contraindications, because we've just heard, you know, Bob and NiCole talk about why this is important. What are some considerations for professionals and for people that are thinking about going into these environments?
Sure. So just to remind the audience, from my standpoint, I do medical fitness, general fitness, and post-rehabilitation. So I'll start with contraindications. In my situation, contraindications are typically addressed at the clinician level, you know, by the doctors or allied health professionals before they're referred to me, such as being symptomatic and having known cardiovascular, metabolic, or renal disease, or addressing things like where they fall on the continuum of stages of change. So by the time the patient gets to me and have been referred for exercise, they're typically medically cleared to begin a program and are usually in the preparation or action stage. So really any other contraindications that would need to be addressed, especially by myself, would relate to orthopedic issues, like having to avoid a certain type of exercise or movement because of pain or apprehension. And I'll usually learn those types of things from the referral source prior to the initial consultation or during the initial consultation when I'm discussing these things with the patient. And as it relates to COVID-19, contraindications would obviously include a lack of the social distancing or not wearing masks, not washing hands, and not disinfecting equipment. And then as far as the indications go, honestly, it's really just the fact that they're going to benefit from being on a guided, structured exercise program to increase their fitness level, and then things like reduce stress and potentially help improve sleep, and to fight the conditions that they currently have, as well as preventing COVID-19 if they haven't contracted it yet.
Yeah, great. And I think one thing that you said there in terms of a structured program kind of resonates with me is that if you can be in a structured program with a professional, you're going to get in and out of the gym much faster than if you're just in there wandering around kind of aimlessly going to machines. And I think that's the benefit of working with a qualified professional.
Exactly at this point. Exactly right. And if I can just add one other thing, typically there's a learning curve that needs to be addressed, and it's just another reason why it's so important to work with a qualified exercise specialist to at the very least guide them in those initial stages with things like proper form and their pain-free range of motion and things like that.
Jeff, I'm wondering if you can contrast for us, since we do have a decent number of fitness professionals I know are watching, the difference in your mindset between working with maybe someone who's a little bit older or immunocompromised versus just your standard general population client, because there definitely is a different framework that you apply there. What does that look like for you?
You know what? I'm going to say that I love this question. And I'm going to say that in my experience, there tends to actually be more similarities than there are differences. So I'll just be really brief about it. From a similarity standpoint, no matter what, and really right now just talking about resistance training, no matter what, they still need to follow ACSM and NSCA guidelines. And, for instance, strengthening each major muscle group twice per week and across the spectrum of repetition ranges, basically RPE driven, et cetera, et cetera. And what the differences tend to be are going to relate to the special considerations for their particular condition. The initial loads are going to obviously have to be much lighter. You're going to have to not just, like, one of the ways I like to explain it is whatever you think erring on the side of caution is, you're going to have to err even more on the side of caution, at least initially. And so the progression rates are going to be slower. The available range of motion is going to be, you're going to be more sensitive about that, much more sensitive about special considerations and things like that.
Yeah, absolutely. I think an adage that I always apply to working with these populations is exercise is kind of like cooking. You can always add, but you never take away after you've done too much.
There you go. Yes.
And there is a tremendous amount of great resources out there, certainly by the ACSM with their exercises medicine credential and some of their other published texts and guidelines on the specific parameters for working with some of these populations. So that definitely would be good resources for people to go to. Matt, let's kind of switch gears to your environment. I know we have some physical therapists and would-be physical therapists watching. You're in a hospital clinical setting. People are kind of exercising with you under a little bit more, I guess, robust suggestion from their physician. What are the indications and contraindications lie in your world, and how are you guys addressing that in the health system?
I think, especially indication-wise, they kind of mirror exactly what everyone has said so far. I mean, you look at the negative impact of delaying or preventing, whether that's treatment or exercise, and all these other comorbidities, what that downstream negative impact looks like. So an indication for that would obviously be giving them the opportunity to present in the clinic and exercise or have that treatment. But another interesting point that I think goes hand in hand with that program is, especially in my world, we're dealing a lot with motor control. And as all of you know, a squat can be done a million different ways for a million different reasons. And I think the importance of having structure, someone come into the clinic to exercise, is to have that professional teach you how to do these right movement patterns. That way you're not causing injury, because anyone could look up a YouTube video on how to do a squat or a lunge and things of that nature. But to be more aware and body conscious, I think really goes a long way in helping achieve the goal that a patient or a client wants. So I think that is a huge indication to get somebody back into the clinic or into the gym, is to really tailor a true program to what that individual needs, whether that's for health reasons or just for general fitness level.
Right. I'm gonna ask you maybe a difficult question to answer, but I think it's probably one that physical therapists are dealing with quite a bit.
Sure.
How are you handling the kind of delineation between the people that are like, no, I don't want to come in. I'm afraid to come in right now because of COVID. And how are you helping those patients navigate the space relative to the severity of their condition? I mean, I would imagine if somebody has mild chronic tennis elbow, you're probably not really pushing them that hard to get in. But maybe in the case of somebody who is, post-op, knee replacement or ACL, maybe that's a different conversation. How are you guys navigating it based, I guess, on severity of condition?
Yeah, so I think originally when we were first rolling back out our outpatient clinics, because a lot were closed for some time, and they had different tier levels, tier 1, 2, and 3 on, what at that time was appropriate to risk versus reward, when we still were understanding, and we still are understanding how this disease manifests and transmits and all that. Now I think it's more or less with the the guidelines that we have set up for safety in the clinic, one-way traffic, for appropriate airflow, PPE, all those things, it's kind of in the court of, okay, we're open for everyone else and all those other injuries, because like you had mentioned, someone has tennis elbow or someone who's just a major post-op. Well, I'd argue to that person, if that person has tennis elbow and the only way they've been staying active this whole time is playing tennis, and now they can't do that, that injury is just as important to them as if someone who was just a post-op patient. So I think we're in that mindset or time now where, it's time to start rehabilitating all these other individuals as well, because just delaying it any longer, we have already seen these negative impacts, whether it's mental or physical health. So I don't know if that answers your question.
I think that does. Basically, it sounds like, initially you did have kind of a stratified system for getting people back in, but now, at least in Michigan medicine, in the in-clinic setting, you guys basically consolidate all those tiers into one, and at this point, with the precautions you have in place, you guys feel comfortable advocating strongly for people getting back in the clinic.
Exactly.
Last quick follow-up. Are you guys still doing some degree of telehealth-based PT?
Yeah, so that's still an option, whether you want it for your initial evaluation or, you have the evaluation in clinic and then you have follow-up with revisits. So yeah, definitely still an option. But like I said as well, it's to the discretion of the patient and what's their comfort level. My opinion is, there's this importance of being in the clinic, being in the gym, understanding the appropriate techniques, body movements, and motor mechanics in order to achieve the appropriate goal, which I just think telehealth is a little limited in. But yeah, those are still options that are there.
Yeah, and for anyone that's interested in learning more about that, that was our first webinar, talk about the rapid pivot to telehealth and virtual fitness. Bob, from your standpoint, kind of 30,000 foot level, you got Matt and Jeff that are in the clinics. You kind of sit above these kind of things. What's your view on contraindications and indications?
Well, I want to put the caveat out there first. I am neither a clinician nor a fitness professional, so I'm a hospital executive by training, and so I do look at it from more of a strategy point of view, more from a physical plant point of view. So I think there's some safety considerations besides, and I certainly agree with everything that Matt and Jeff have said, as you've got to look at an individual's certain personal conditions and whatever indications they might have. But beyond that, I think you've got to take a look at what is the physical environment. Do you have a facility that's going to be capable of allowing you to let people in an enclosed space safely? So we look at things like the number of air changes per hour within a given space, what level of filtration is available in the air, what level of disinfection do you have in the air, do you have an ozone system in place, do you have a scrubber, if you will, within your HVAC system, those kind of things that allow you to get enough air turnover and entrapment of viral load, viral particles in the air, that you can continue to provide a safe environment in an enclosed space. So there's a number of things that go along with that. Certainly continuous cleaning, hand washing stations, that kind of stuff. And then the big question that we get is that when you allow people back in the facility to mask or not to mask, that's the big question. And I don't think anybody has definitively answered that yet, because if you look at, there's a division between what the World Health Organization says and what the CDC says. So World Health Organization says don't wear a mask while you're exercising. The CDC, through their NIOSH division, says, well, as long as you're not doing any high-intensity exercise, you can still exercise while wearing a mask. So if you're doing strength training or whatever, you can wear a mask. And you should, but the problem from my perspective about wearing masks is that once mask gets wet through either condensation of breathing or sweat or combination thereof, they become ineffective and they become harder to breathe through, and you start getting oxygen deprivation when people are breathing hard. And I think it was based on that piece that we came up with the only way that it's safe to exercise inside, even with appropriate airflow, is with the enhanced distancing. And without masks. That's our personal recommendation. And I think that's the overcoming people's fear is probably the biggest way of that's a big contraindication for people is fear. And so unless you can exude safety, exude that sense that people can feel, can trust your organization, can feel like they can come there without the risk of getting ill, or at least a minimal risk, then I think those are kind of the physical environments, the physical contraindications that you ought to take a look at is, can we safely do it? And if you can, then you can overcome that. It's then a matter of building trust and relationship to get people back in.
Right, right. And yeah, the mask part of this is very, very interesting. I mean, certainly there's the larger political controversy on masks, but I mean, apart from that, it does actually become a really interesting discussion with regard to exercise. And I'm going to throw it out there to the group. I don't want to throw it out to anyone in particular, see if anybody wants to answer. If you don't, by all means, no need to. But for the populations we're talking about, the elderly, immunocompromised, maybe people that aren't working out at such a high intensity, does anyone have even a reasonably evidence-based opinion as to how they would recommend these individuals exercise with or without masks? I mean, I understand if you're doing a heavy, high-intensity interval workout, you're breathing heavy, and that mask is wet, it's probably not going to be very effective. But I'm thinking of the 65-year-old person who's maybe not exercising all that hard. Would it be more appropriate for them to be in a mask? I know there's no clear-cut answer, but I'm curious if any of you have an opinion one way or the other on that.
Well, Matt, it depends on who they're with and where they are. And so who they're with, if they're exercising alone, and I know that the focus of the conversation has largely been on exercising within facilities, I would like to talk about external to facilities. And we have all noticed an uptick of people who are exercising outside, either in the built environment, on sidewalks, or in bike lanes, or in a park space. And if they're alone and they're using their own equipment, or if they're living with somebody and they're using their own equipment within their own family and there's no one else around, it's perfectly fine to exercise without a mask. Similarly, if they are riding a bike or on a sidewalk in an environment that's not packed, then it's perfectly safe for them to exercise without a mask. It's when, and Bob mentioned, that when you start engaging with other people and you're increasing the intensity of what you're doing, then it's the time to wear a mask. But there is this balance of the reduction in airflow and the cardiovascular load that a mask places on an individual, and especially an older adult. Your question also struck me because you selected the age of 65. And most of the people that I work with are older than that, and they're highly fit and they're exercising. And so I'd like to think about prevention too, so that if they're no longer comfortable going to a facility and exercising, here are some more opportunities to demonstrate via fitness professional or via some other resource of how to remain active and safe at home. And so I think about the YMCA that's providing a lot of programs for older adults to exercise virtually with a trainer who can watch them. And then I just also want to put out there, in terms of park expenditures and infrastructure expenditures, we've really been talking about individual responsibilities. It's also the responsibilities of city planners and policymakers to be sure that they're investing in the infrastructure so that older adults and everyone can exercise safely. You know that ACSM just released the Anthem American Fitness Index, and one of the outcomes of the index demonstrated that cities that have higher walk scores, higher bike scores, cities who have a higher level of park expenditure per resident are healthier than cities who don't. The average is $99 per individual. Minneapolis spent $263 per individual. I live in Indianapolis. We're not doing well, $36 per individual. We scored very low on the index. Cities like Minneapolis and San Francisco scored very high because they're investing in infrastructure so that older adults can go outside, exercise safely, and in the instance of COVID-19, do so with a lot of space in between them and people with whom they don't live.
Yeah, I want to highlight two things you said for everyone that I think are really important. One, I kind of arbitrarily chose the 65 range as an elderly individual, but the reality is we all know that there's a big difference between chronological age and biological age. I mean, I've seen some 75-year-olds who are fit like 45-year-olds, and unfortunately some 45-year-olds that seem like they're 75 years old. And I think, and this is kind of to Jeff's point earlier of making sure you really have kind of that individualized approach to your prescription. But the other thing, and I think you nailed it, I think it's been one of the biggest struggles of our industry thus far, is we're very myopic in the sense that we only think of this in-facility exercise type of paradigm. And I think this has really shown us that, hey, we need to come up with some alternative modalities. And NiCole, I want to come back to what you said a little bit in the next question when we start to talk about barriers and things like that, because I think what you mentioned about some of these limited resources that are given to the cities to be able to build these environments are a big limiting factor. Did anyone else have any kind of additional thoughts on the, when you should be considering wearing masks versus not wearing masks relative to intensity of exercise and or maybe age and or disease state of the individual?
The only thing I was going to say is that even though I'm pretending with my background that I'm sitting at Venice Beach in LA, I'm coming here from New York City, which, as you all know, was epicenter of the world for a while. And I run my business out of 2 independent physical therapy clinics, and we require masks. So I just want to throw that out there. It's required here. But having said that, as NiCole had alluded to, and possibly Bob as well, the intensity, since I'm primarily just doing resistance training, the intensity is low, and so it's just not causing condensation on the mask, and it's not causing any issues. And I absolutely train this, more senior population, 70s, low 80s, and they haven't had any issues with it.
Matt, just out of curiosity, what at Michigan Medicine, what are you guys recommending with respect to masks for your patients?
Yeah, same thing, masks when in treatment, and then the provider, we have a little bit more PPE, so we wear the masks, and then we wear a face shield as well.
Okay. And then Bob, I guess I'll just kind of finish this up with you. What are you hearing from your member facilities in terms of what they tend to be doing and recommending?
It's across the board. It's across the map. We certainly require all of our staff to wear masks and face coverings, and it's optional currently for members. In most of our facilities, there are a few where their medical directors have insisted that they wear a mask, and so those facilities do that. But most of our members are not. And by the way, I'm 63, so I don't appreciate the 65 comment.
Well, I could have said 62. I mean,
you could have.
I could have.
Yeah,
no, I mean, it's interesting. And guys, I mean, like everyone that's watching, I wish that we could have given you a more succinct and direct answer with regard to masks, but I think this has been one of the challenges of this pandemic, and then exercise just adds another layer. With that said, there are some limitations and some barriers that just exist in general to working with this population, and then COVID just amplifies these kind of things. And I think I want to start this on like a very tactical level with you, Matt, and then we'll kind of scale this up to Bob and NiCole with maybe kind of the more overarching view of this. What are some of the limitations and barriers that you run into in general, and then maybe specific to COVID? Yeah,
I think the specific to COVID, especially now, and it was a limitation for us too. It was a big learning curve that you mentioned earlier. It was just this whole telehealth technology thing. My profession is a very hands-on profession, and then all of a sudden that was taken away, and we had to kind of shift gears and say, how can we still reach these populations and still be effective in what our treatments are? And so that was a big challenge as well, which is why, I still think we kept some clinics open for certain populations to come in and get treatment. I think other barriers with this population at times too is just the stigma of what exercise is. And so really, I think education is powerful intervention tool as well. So why are you doing this? What is this going to help improve? What system is this going to impact? How do these other systems impact one another? So I take pride, and I take a lot of time as well, using education as an intervention. And I'll talk about this later as well, but I think it's very important to educate them on not only why exercise is good, but what sort of responses they should be seeing from exercise in regards to how they're feeling, whether that's with RPE scale or what their heart rate's doing, what their blood pressure should be doing. And like I said, later, I think we could talk more about this, but I think in this new COVID world, it's going to be a big deal on educating this population on how to be aware of certain vital signs and things like that to help address any negative impact or exercise intolerance.
Yeah, it's great. And Bob, going to you, I mean, in terms of this, again, this is certainly these populations are very prominent in medical fitness centers. There's the general challenges, and then there's the more COVID specific challenges. Why don't you speak to that a little bit?
Yeah, I think the barriers for both dealing with COVID and non-COVID environments are not that different. And I think the first one is a sense of trust. I alluded to a little bit earlier, and probably even more viscerally, a sense of security. The reason that many seniors join medical fitness facilities is because they have the security of knowing that there's a relationship between their fitness facility and their physician. So if something's going on, there's some level of communication that can go on back and forth. And so there's an innate sense of security that comes from that internal relationship. And that's critical to maintain. But specifically during COVID, it's interesting because we find in a large number of our facilities that it's our older clientele that are the ones that are clamoring more than the middle-aged and younger clientele to get back into the facility and exercise. Because I think many of them, because of education that Matt mentioned, and people have become aware that how important exercise is to their health in this population that has been, this older population that has been exercising, that they really miss it more than anyone else when it comes down to it. So we've actually had to slow them down some in many cases about coming back, which is a good thing. But for those that aren't, it's pretty much like Matt said, there's a lot of education involved. There's a lot of reassurance. There's a lot of putting in place safety measures with we call it conspicuous cleaning. So that it's very obvious that certain sections of the facilities are closed down at certain times of the day while deep cleaning is done. So that's it's very obvious, it's very clear. Of course, all the hand washing stations or hand sanitizing stations, and what we've also done in our facilities that I think has gotten a little traction with people is we begin to hold people individually responsible for cleaning up before and after themselves and wiping down equipment that they may use. And we found that most of our members, get into that. They appreciate the fact that we're asking them to do that. Staff then, also serve then as reminders and enforcers to make sure that happens. Or if someone refuses, they'll wipe down the equipment before the next user's there. So that we can make sure that there's disinfectant applied in an adequate amount of time to allow everything to be disinfected between every use. So I think when people begin to see all the physical measures that are put in place to make sure that they have a safe environment, then they're less reluctant to come back into the facility in COVID. In a general basis, I guess when you talk about the older adult, what drives them into facilities or not, and how do you overcome some of that? I think a lot of it is a perception that it's harder for older people to get in shape than it is for younger people. People that have been sedentary for a while, they get a little stiff in the joints. They lose some range of motion. They certainly become less flexible. But it's helping them understand and educating them that, hey, the 95-year-old has the same capacity to build muscle as does the 55-year-old if they're trained properly and if they do things appropriately. And it doesn't take too long for people to begin to see the positive changes that occur either in their personal health or in their fitness, or if they're dealing with a chronic disease, the impact on that chronic disease that exercise might have, that you quickly gain their trust. The key is to get them in, to get them trying, and if you can get them to commit to 4 or 8 weeks, then you can begin to let them see that there's going to be a positive change that comes. That's typically how you have to do it to get started, is to give people a short-term something that, hey, I can get through anything for 8 weeks, right? So if you get them into a program where they they can see the difference themselves, then I think it's much easier to build that relationship with them. And with the relationship comes trust, and with trust comes belief, and with belief comes the medical connection that keeps them coming back. And once you have them in that connection, you'll have a client for life, pretty much.
Yeah, the population is definitely a very, very loyal population. Bob, I'm wondering if you guys even anecdotally have had any data on what your centers are seeing utilization-wise relative to pre-COVID. And I don't know if it's stratified down to the level of age groups, but I think that would be interesting for us to hear just kind of what you're seeing reflected in utilization rates.
Yeah, we actually have done a survey of our members, and we're waiting on some of that data to come in to stratify it. So unfortunately, I'm not able to stratify it for you today. But I will tell you that most of our facilities that have reopened, because there's a lot that still have not reopened across the country. But the ones that have reopened have seen about the same trajectory. The first week that they're open, they're probably at 15% of previous utilization, and it grows over the first month to around 30 to 45% utilization. That's where most of them are at this point. It's still at the 45% utilization of pre-COVID right now. Part of that is because they are limited, and many of them are limited to seeing only these physician-referred clinical patients. And part of it is there's a few of them that have reopened all the way, and part of it is the fear in the general population about coming back. So there's some, we're seeing maybe 10% membership cancellations across the board. People that just say they're not coming back because you just don't trust it. But that's actually lower than we thought we would see initially. But that's about what we're seeing. But as far as definitive data, Mike, I really can't give you anything more than that at this point in time. It is pretty much anecdotal. Hopefully another couple of weeks from now, we'll have a little more meaningful data.
Yeah, we're all trying to spin in our wheels to collect data as quickly as we can. I know IRSA has published some data as well through some of their survey tools. That's certainly something that anyone who's listening can access. It is interesting to see what these utilization rates look like nationally, because I mean there are true business implications to these things as well. NiCole, we're gonna switch gears here a little bit, and you and I talked about this pre-webinar when we chatted last week, and you alluded to it a moment ago when you started to talk about some of the barriers on like an access and like a socioeconomic level. We're actually going to do a webinar relative to this in September, more on that to come. But I'd just like to give you the opportunity to talk a little bit more about that specifically. I mean, yes, there's the barriers of fear and COVID and all that, but there are some other barriers that exist that I don't think your standard, certainly fitness professional considers, because typically we're working in facility and we're working with a population with a larger amount of discretionary income. So let's go back to what you were saying earlier, just to make sure we at least round that out to a certain degree for this conversation.
So older adults in the U.S. today, for a good percentage of them, they don't have a large amount of discretionary income, nor do they have a large amount of discretionary time. And COVID-19 has shown a bright light on those individuals who are living in multi-generational homes where maybe the older adult was working and has been furloughed or has lost their job. So now there's even less discretionary income, and perhaps the grandchildren are home and the older adults are responsible for childcare and for e-learning. So time and income become barriers to being physically active, even in the older adult population. But for those older adults who do potentially have discretionary time and maybe discretionary income, and as Bob was saying, are maybe reluctant or refuse to go back into a fitness facility, and also are not welcoming people coming into their homes, that they're very afraid to have people just come into their home and bring in COVID-19, which is one pandemic. As I was listening, I was thinking, we're not talking about the other pandemic that's happening in the United States today, which is racism. And so in terms of safety and going out, there are a lot of protests that are very safe and controlled, but there are a lot of protests that are not. And as older adults are paying attention to what's happening in the media, there's even this fear of going outside and worrying about what they might encounter in terms of angry groups of people or in terms of law enforcement. And so it's really important also to communicate, not just from a built environment perspective and not just from a safety perspective, what older adults are going to encounter when they leave their homes. And so it is a barrier because traditionally fitness professionals will say, well, I'll just come to you. They don't want that. I was sharing that I work in the Center for Aging Research, and a lot of our research happens when we visit patients in the home, and they won't let us in. They might meet us on the sidewalk or on the front porch of their house or in the lobby of their apartment building, but they're not welcoming our research assistants into their homes anymore, and we have historically never had a problem with that. People are afraid to leave, and they're afraid to let people in, and it's a barrier. And so that's why I mentioned earlier that we have to pivot to, first of all, invest in infrastructure so there's more space so that people feel safe. And for Jeff in New York, probably it's not going to happen. And I kind of stayed away from New York City because it's such a crowded area. But for places that have a little bit more green space that can be developed so that physical distancing can happen among older adults, it's something that our policymakers have to pay attention to. And for fitness professionals, it's really important that they take this opportunity to pivot. And maybe they can't invite somebody into the gym because there's not space, or more likely because the older adult isn't comfortable, but find other ways. And that's what we're doing by meeting with older adults virtually. And they're quick learners. I will say very few of the people that we worked with previously to COVID got on Zoom or got on FaceTime, but now they're willing to learn. It's how they're engaging with their grandchildren if they live far away. It's how they're engaging with friends they haven't seen from church or from other social clubs. And it's how we can engage with them for physical activity and exercise.
Yeah, that's great. And I was actually thinking about asking you, but I think you kind of answered it in there. You know, as president of the ACSM, I mean, you have a very prominent space to hold it with fitness professionals. I was going to ask, you know, what fitness professionals could do right now, but I mean, you said it, it's starting to get creative with how we provide service to these populations and not think just in terms of our traditional in-gym or in-home paradigm that we've used for so many years.
So I will say that this week, and it's only Wednesday, I have interacted with 5 fitness professionals, not that I was using, but I was in meetings with them, and they're all really thrilled about the interaction they're getting virtually. So for the American College of Sports Medicine, we've got this really uncomfortable balance where we're seeing a slight uptick in fitness professionals who want to renew their certification or get new certifications because they want to be able to do personal training in a safe way virtually. Where on the other hand, we're watching facilities suffer because attendance is low, and we want all of our fitness professionals or our allied health professionals to be successful. And so it's really this balance of what is the right message, because we want people to go back to the gyms, but we also want them to be safe. And we don't want, just because they don't want to go back to a fitness facility, for them to stop exercising. Because no matter what, and we've heard it from everyone on the panel, everyone who is an older adult, well, everyone, but especially older adults, need to remain physically active during these pandemics.
Yeah, that's great. One more quick question. I mean, we typically, your standard fitness and allied health professional doesn't think in terms of larger public policy and built environment and things like that. That's just not the frame that we tend to view the industry through. I'm wondering if there's any suggested resources for people that are interested in learning more about the policy area or built environment and whatever, that you might be able to direct people to, because I think this is also a great opportunity for people to just become more educated on some of these larger issues.
Well, as I mentioned, the Anthem American Fitness Index that was released by ACSM in July has all kinds of information about informing policymakers regarding the cost of increasing physical activity possibilities. And there's also resources about gardening in there, to community gardens, but lots of resources about how to engage with it personally as a community or to inform policymakers. Our Exercise is Medicine website through ACSM, so it's just EIM.org, also has a lot of good information for fitness professionals, for clinicians, and for individuals who want to influence how to make their environment a healthier place for physical activity participation.
Yeah, great. Well, guys, we've got about 10 minutes left, and I think we need to get to the most tactical layer of this, which is, all right, what are best practices for working with this population? And I'll start kind of with our clinicians in Jeff and Matt, and then we'll kick it up to NiCole and Bob if they have anything to add. But Jeff, we'll start with you. I mean, what are your best practices in your take homes for the professionals that are listening to this that either are working with these populations or are considering doing so because they realize its importance?
Yeah, I'm going to break this answer down into just a couple quick categories. One, starting with the initial consultation, best practices would include things related to the psychosocial aspects, such as actually what we've been talking about, showing empathy, having a listening ear, listening to and addressing any concerns about safety because of COVID-19, allowing, I love during the initial consultation to allow some autonomy, allow some input into their program design by asking them what would they like to have included or what would they like to avoid? Do they have any apprehensions about any things? Just to do things necessary to gain their trust. Also, it's critical for the trainer to implement a concept called readiness to train prior to each session by asking them asking the client a list of questions such as, how do you feel? How did your body respond to the last session? Did you take your medications? Are you on any new medications? Have you eaten? And things like that. And as I mentioned earlier, it's also critical to know the special considerations for the conditions that they might have, which could include things like needing longer rest periods between sets, ensuring the environment isn't too warm or humid, addressing possible inability to get up and down from the floor, and understanding joint-friendly exercises for the knee, spine, and shoulder pain. So those would be things to do or think about prior to designing the program or prior to actually performing a session. And then when it comes to the actual design of the program, I like to break it down into two phases when it comes to resistance training. The initial familiarization phase, which I call a learning phase, where you continue to establish trust by following the ACSM guideline to start low and progress slow. I use this phase to determine their available pain-free range of motion. What I actually do is I perform a joint range of motion assessment from their great toe to their neck and everything in between. It's a passive unloaded assessment. I just want to take their joints through their ranges just so I can get an idea before I even see them move on the gym floor. I'm also going to know some of the stuff through the referral and through the initial consultation, but I just actually want to see their joints move through their ranges, get an idea of asymmetries, apprehensions, things like that. And then I'll also use that familiarization phase to do obvious things like teach proper form, the flow of a session, and make sure their body's responding well from session to session. So the purpose of the initial phase, or the familiarization phase, is to establish that safe baseline or put them in a nice safe box that you can then progress out of. And then just real quickly, because I could talk about this for 5 hours, progression, but the gist of the way I progress out of the initial phase, where during that initial phase, I typically start them somewhere around 10 repetitions per set. At that point, I begin periodizing. So in other words, I'll determine what rep range I'm going to have that person train in, and let's say it's the 8 to 15 repetition range. So I'll typically move them up to 12 to 15 and then stay there for a 2 to 4 week phase, get them stronger in that phase, and then move them back down to 10 to 12 for probably a 3 to 4 week phase, 8 to 10, and so on. But the point being is that it needs to be on the front of the trainer or the coach's mind to safely improve their fitness level so that their body has the strength and conditioning to fight any current conditions they have, and obviously COVID-19. And then the other thing I want to mention is virtually I actually don't have a whole lot of experience since it's so new, but what I've learned in the little amount of experience I have is that the best practices really depend a lot on the environment and the learning curve. So for me, it's actually been a cumbersome experience with moving laptops and phones around. And since it's New York City, having lack of space and lack of equipment and stuff like that. So I like to use the virtual time to really address the learning curve and to show them how to set up a proper program and things like that.
Yeah, that's great. That's great. Yeah, there's a lot of considerations, and certainly when we're talking about working with these populations, with the older adult population, there are some general guidelines that you can certainly apply. But as soon as you start to get into specific orthopedic issues or other medical conditions, then obviously there are more standardized guidelines for that. And again, to mention again, the ACSM and a lot of their resources are a great place for professionals to go to look at that more specifically, as well as, Jeff, you mentioned this, you get a lot of referrals directly from physicians. maybe this is not what a lot of our professionals actually have the ability to get. So opening up those lines of communication with physicians wherever you can is also a critical part of the process.
Yeah, if I could just say something quick on that, that's one of my biggest passions in my profession. You just hit on this disconnect between fitness professionals and clinicians needs to be fixed. And what I do when I preach on this stuff is that initial consultation is the perfect time. So if you're in a community setting, a health club, an independent gym or whatever, that's your time to get the okay from the potential client that you're doing your initial consultation with. Hey, do you mind if I connect with your so-and-so? And then use that as the time to make that connection, so that we can start bridging this gap.
Yeah, I'm afraid to even enter into that discussion with the people that are on this call, because we could probably go till 10 o'clock tonight. But I think you're speaking to all of our hearts there. Matt, anything to follow up on there from what Jeff said in terms of programming and progression?
Yeah, just real quick. I mean, he did a great job at touching on everything, but I just think one thing that I'm changing in my practice, and not only do I challenge other physical therapists, but all exercise professionals, is just pay attention closer to signs and symptoms of exercise intolerance. It's very easy to just give a rest break and say, oh, you'll recover. But I really think diligently screening and continuously looking at heart rate, blood pressure, oxygen saturation, they're just such easy things. And we have the ability to do that so quick now. And I just think with this whole pandemic, because I can get into it, but I think it would help identify a lot of downstream issues and also help you progress as well, because we're just on the front of this recovery. Because I think pretty soon in this category, you can throw in the post-COVID, survivor who had this, and to talk about debility and exercise intolerance with them is just unremarkable what we've seen so far. So, a lot to come on that, I think. But yeah, just really challenging yourself to take a step back from what you're trying to accomplish, and paying attention to vital signs is huge, I think.
Yeah, absolutely. NiCole, Bob, anything to add from a best practices standpoint we haven't already touched on?
Just a couple of things, Mike, because I want to touch on something Matt just said. Something we don't really know the ramifications of just yet is the post-COVID survivor. One of the things that we're starting to learn about some of those folks is they come away with some lung scarring, they come away with some cardiac issues. The virus attacks different parts of the body, it's not just a respiratory illness. So the whole post-COVID syndrome, for lack of a better term, is something we all have a lot to learn about that will impact our older populations as we exercise them down the road. But the other thing I wanted to touch on is the virtual piece. Prior to March of this year, there was pretty scant stuff going on virtual. I mean, there was the Pelotons and there was folks reaching out into the home market, but there wasn't a whole lot of large scale virtual training going on. But the whole industry, as you've seen, has pivoted. A lot of facilities are generating their own virtual content and putting it out there. But what we're starting to see develop, matter of fact, I was talking to a new player in the space that's just coming out this week, where they're actually incorporating artificial intelligence into their platform that's going to be able to allow trainers to do virtual training, but at the same time, they're going to be able to interact with that individual. They'll be able to look at posture. They'll be able to look at form and doing things just by using the person's mobile phone camera. They're going to be able to apply artificial intelligence and get feedback on how well and good format, a good form that people are using in the exercise. So you can address that on the spot, make sure people are continuing to exercise safely in their home, and that's going to be new. So it's actually pretty exciting to see how rapidly this is coming along and how rapidly it's developing. And we're going to see some great breakthroughs, I think, within the next 9 months in this area. So something to watch for. It's certainly virtual. It's important now, but I think it's going to get a whole lot better as we move forward.
Awesome. Yeah.
And just if I can add one other thing to what you were talking to NiCole about just a second ago, I know we're running up on time, But in terms of a resource for what's going on nationally, I would want to put a plug in for a group called the Physical Activity Alliance that NiCole's ACSM and we're a part of. They're getting all into the streetscapes. They're getting into Department of Transportation funding. There's a whole lot of resources on the Physical Activity Alliance page. They're also I'm working on a subgroup trying to develop some CPT codes for exercise referral, for physician-referred exercise reimbursement eventually. So hopefully that's all coming down the road over the next few years, but important stuff from an advocacy point of view.
Awesome. And we'll link some of these resources in the email that we send out to everyone afterwards, just so you have a chance to have access to those. NiCole, anything you want to bring us home on?
I just think the last word that we all agree that everyone should be exercising, but it's not just an individual responsibility. It's the responsibility of people who are influencing and forming policy, as well as the policymakers themselves. And so collectively, we have to work together to make sure that everyone has an opportunity to be physically active before we ask them to do so.
Absolutely, yes. This is a time for collaboration. And I think this is a testament to that collaboration, all of you on here today. Well, I thank everyone so much for their time. This has been incredibly informative. Again, attendees, you'll be getting an email that has a link to this with some of the resources that we talked about. I'll make sure that gets out to everyone. Be on the lookout for one more webinar coming in early September about some of the things that we were alluding to with NiCole. I think that's going to be an interesting conversation. Thank you so much to our panelists and everyone for joining us. Have a great day.